Hi, it's Dr. Pearlz Clinical Rounds, here with the case on forearm laceration. Let's get right into it. 45-year-old male presents to the clinic with the complaint of a cut to his right forearm. The injury occurred 4 hours ago after he accidentally scraped his arm against a clean metal object. He reports bleeding from the site of injury and has tried applying pressure to control the bleeding. Last Tdap is unknown, but he is up to date on childhood vaccinations. Patient denies exposure to water sources, dirt, or excessive debris. Patient is not on any anticoagulants, has no medical conditions, and has no known drug allergies. Patient reports pain but denies weakness, numbness, or tingling, or loss of sensation. On exam, patient has a 3 by 0.5 by 0.3 centimeter linear laceration on the lateral right forearm. There is no evidence of foreign body, and the depth is down to the dermis. There is no sign of neurovascular compromise. When evaluating wounds, it is important to determine the following elements. Determine the mechanism of injury. Is it an abrasion, puncture, crush, avulsion, stab, or laceration injury? Determine the time since injury. Is it an acute or chronic wound, meaning greater than 4 weeks? Generally, for primary closure, most acute non-infected clean wounds in healthy individuals can be repaired up to 18 hours following injury, and facial wounds may be closed up to 24 hours following injury through primary closure. Determine the environment in which the injury occurred. Is there a concern for contamination or infection, such as with bite wounds, or exposure to water sources such as seawater or fresh water, or soil? Determine the size, length, width, depth, shape, and location of the wound. Is it a superficial wound, such as the epidermis, or a partial wound, epidermis and dermis, or a full thickness wound which extends from the epidermis, dermis, subcutaneous tissue, muscle, with possible involvement of bone, tendon, and nerve? Injuries that involve tendons or ligaments, joints, muscles of the hand, open fractures, nose, eyelids, lacrimal duct injuries, neurovascular compromise require management by a specialist. Determine if there is devitalized or necrotic tissue, or for other signs of infection. Remove devitalized or necrotic tissue to decrease the risk of infection, or refer to a specialist. Determine if there are any foreign bodies in the wound. Assume all wounds have foreign bodies and thoroughly evaluate. If your suspicion is high but you are unable to visualize a foreign body, you may need imaging such as X-ray, ultrasound, or CT. Determine the tetanus immunization status. If it is a clean and minor wound, and the patient has completed their primary tetanus and diphtheria series, and it is within 10 years since the most recent dose, no vaccine is needed. If they have not completed their primary series, age-appropriate vaccine is needed. If the most recent vaccine has been more than 10 years and the primary tetanus series is complete, vaccine is needed. For all other wounds, if the patient has completed their primary series and the most recent dose was within 5 years, vaccine is not needed. If they haven't completed their primary series, age-appropriate vaccine and tetanus immune globulin is needed. If the most recent dose was more than 5 years ago, age-appropriate vaccine is needed. Determine if any comorbidities such as autoimmune disorders, malignancy, history of keloids, anemia, diabetes, or immunocompromising conditions exist that may complicate wound healing. Determine if the patient has any allergies to anesthetics, epinephrine, antibiotics, or latex if latex gloves are being used. Determine the cosmetic significance of the wound. It may be a wound that requires a plastic surgeon. Now that you have evaluated the wound, it is time to gather and set up the necessary equipment for wound repair. Ensure that you have adequate lighting for the procedure. You will need personal protection such as gloves, sterile or clean, eye protection, gown, and face mask. You will need anesthetic with or without epinephrine, an 18 gauge and a 27 gauge needle, and a 10 cc syringe. You will need a laceration repair kit that contains a needle driver, forceps, scissors, sterile drapes, and gauze. For irrigation, you will need a 30 to 60 cc syringe with a splash guard, sterile saline or tap water, and something to collect the fluid from irrigation such as a kidney basin. Prepare antiseptic solution, chlorhexidine or povidone iodine. Prepare materials needed for dressing such as non-adherent gauze, bacitracin, sterile gauze, gauze roll, or tape. Finally, you will need the correct suture material. There are multiple different types of suture materials. It is important to familiarize yourself with the different types and indications for laceration repairs. There are two main types of sutures, absorbable and non-absorbable. Absorbable sutures do not require removal and typically degrade in less than 60 days. Absorbable sutures such as Vicryl and chromic gut are typically used to close deeper wounds such as subcutaneous tissue, intraoral mucosa, and the tongue and nail beds. Non-absorbable sutures require removal and are typically used for surface wound closures. In general, most simple laceration repairs will be closed with non-absorbable sutures. Examples of non-absorbable sutures include Effilon, Prolene, and Silk. It is best to select the smallest suture size to decrease tissue reaction and for cosmesis. In general, keep in mind that the higher the gauge number, the smaller the size of the suture. In our patient, a 4-0 non-absorbable suture is selected. Extremities can be repaired with 4-0 or 5-0 sutures. If there is concern for high tension, use the 4-0 as opposed to 5-0 for greater strength. Now that we have gone through the evaluation of the wound and set up for the procedure, let's move on to the next video for the actual repair of the wound.